A very warm welcome to all of you who have joined us this evening. By way of a quick introduction, my name is Anjay Gregory and I am the CEO of Zebra Medical. And this evening we are delving into the world of PICC-Ports and the user cases for these devices that are emerging within the South African context. I'm hoping that you all caught our newsletter from this month, which was literally finding PICC-Ports their rightful place under our African sun. Before we can get into this topic, however, I just have some housekeeping to take care of, so bear with me. A quick webinar indemnification notice, and I'm going to try read this as speedily as possible. To all of the attendees today, by continuing to participate or view this webinar, you acknowledge and accept that all the information shared by the presenters and the panelists is provided for general educational purposes only and does not constitute medical advice. Neither Zebra Medical or its representatives nor the participating doctors accept any liability for the loss, injury, or damage arising from the use or reliance on the information provided. Clinical decisions remain the sole responsibility of the attending healthcare professional. If you remain in this webinar or you view a recorded version, it will be deemed that you have read, understood, and accepted this indemnification in full. Okay, thank you for that. And then just an extra set of house rules, please. Remember, microphones need to remain muted. Questions are, of course, welcome. You can type them into the chat box at any time, and we will endeavor to cover as many as we can at the end in the dedicated Q&A time slot. Please bear in mind that the session is being recorded. Sorry about that. There you go, everyone. No AI-generated recordings or bot participation, please. I did see that something has already popped up. If you don't mind, please closing it down. Be respectful and professional at all times. Thank you. And then please stay engaged. Once again, the fun part of this webinar happens at the end where we get to ask our panelists questions. So quickly, something about PICC-Ports. It's probably the vascular access device that has evolved the most over the past 10 years. At Wacova this year, we had the likes of Dr. Pitaruti and Dr. Pinelli and many others espousing the benefits of this device and advocating for its use, in most cases, before a chest port. However, notwithstanding the extensive use of this device in Europe, it remains a relatively new concept in many countries, including South Africa. And Zebra Medical is proud to say that we've recently launched our PICC-Port, being the Vigon PICC-Port. And the likes of this formidable panel of experts have already started using, and they've discussed this device and the success that they have had so far. Unfortunately, this evening, our panelist, Dr. Fatima Hussein, cannot join us. She is ill. Fatima, we obviously wish you a very speedy recovery so that you can join us next time. Moving on to our next panelist, being Dr. Hugo Minard, an experienced medical professional serving as the Director of Critical Care and Emergency Services, recognized as a pioneer in ultrasound-guided vascular access in South Africa, and specializing extensively in advanced vascular access procedures, having done as many as 22,000 lines across intensive care units and emergency departments. We are also joined by Dr. Liana Root, who is a specialist breast and endocrine surgeon based out of Cape Town. Her work bridges academic and private surgery, public sector advocacy, and integrative medicine. She serves as the executive director of Project Flamingo and serves again as executive director on the Cancer Alliance of South Africa. We are then joined by our third panelist, Dr. Stefan Besson. He is a hospitalist and sonologist who works for ER Consulting out of Nelspruit. He has over 15 years experience in acute and critical care, and he brings with him extensive procedural expertise in point of care ultrasound, intensive care vascular access, alongside with strong clinical leadership in terms of advanced emergency services. Our panelists this evening will be sharing their experiences as to why they believe the PICC-Port can indeed revolutionize patient care, specifically within the South African context. Our moderator this evening is Dr. Luke Sampson. He is an accomplished doctor and healthcare leader with extensive clinical experience in emergency medicine, strong corporate background, and his expertise spans digital health, clinical governance, and innovative hospital-at-home care models. So without further ado, let me hand you over to Dr. Luke, who you can now see in the flesh, and he will give us a quick overview of the panelists and what they're going to talk about this evening. Thank you again for joining us. Luke, over to you.
Thanks, Anja. And also thank you again to you and your team for the honor and the privilege to do this now, the second webinar and duty of moderating these. And always very interesting. Just a reminder, everyone who's in attendance, before we get into our speakers' talks, we will have a scheduled Q&A session after all of the presentations have been completed. Just to draw your attention to the bottom of your screen, you'll notice there's a chat button and a Q&A button. If you have questions, please field them in the Q&A under the Q&A button, and any chats are welcome so long as they abide the house rules as outlined by Andre in the chat section. So without any further ado, I'd like to introduce our first speaker and first topic for the evening. Dr. Hugo Minnaar will be speaking on PICC-Ports, the Wokova experience. I think a very interesting overarching topic for the evening. Hugo, over to you.
Thank you, Luke. Hello, everybody. Hugo Minnaar. I'm a specialist intensive care technologist, and I am going to give you some feedback on the World Congress of Vascular Access, which I went to specifically to look at PICC-Ports. So let's jump off and look at that immediately. Just a quick conflict of interests, if there might be. I present these courses on behalf of Zebra Medical. I've got a vascular access team in Pretoria where we serve about 11 hospitals, and I'm involved with the University of Pretoria's Skills Training Laboratory. So basically what happened is that I went to Florence in Italy last year in October for a short fellowship in PICC-Port insertions. There wasn't really any PICC-Port insertions. Patients had a lot of punctures when they received chemotherapy. So I went there in October to learn PICC-Port insertions. I was doing a lot of PICC lines. We were doing about 100 to 200 PICC lines per month. So PICC-Ports were naturally the next thing to come. When I came back, didn't put in a lot of PICC-Ports, but I did get some experience, and I'll show you the first one that I did. But luckily, I had the opportunity to go back to Valencia in Spain just now recently, where the World Conference was, where all vascular access specialists comes together, and they listen to the publishers, the authors, the people that research. And some of the great authors was there, Pinelli and Peter Ruti and so forth. Pinelli specifically for PICC-Ports, that is why I went. And he gave us a lot of information and research on PICC-Port insertion. It has been a conference been going on for a very long time, very well organized, everybody from all over the world. Unfortunately, South Africa not represented, no research from South Africa really. And that is something that we can change in the future. The conference arranged by Wokova, and with them is GlovaNet, which is a sort of umbrella for the Gavi guidelines and the Gavi-PED guidelines. And the Infusion Nurses Society falls under that, and the Association for Vascular Access. When we look at guidelines, we refer to the Gavi guidelines, and they've been looked at in 2023 and so forth. I think the Gavi-PED guidelines is even more recent. In South Africa, we don't really have anything, but we have started something. It's a Vascular Access Association of South Africa. That's the link that links you to that group. Currently, everybody will just belong to it. We will share vascular access information, and we've just elected 12 people from 12 different disciplines to join. So getting back to PICC-Ports, and I will assume that you would know what is a midline and a PICC line. I'll quickly show you because Stefan will show you a bit later how the insertion of that works. But traditionally, your cancer patient had a chest port, and that was from long, long ago. And then they tried to move it to the brachial port or the antecubital fossa port. That didn't really last long, a lot of complications. And then in 2017, they started with a big port, where they took the PICC line and married it with a little port, and we had then access to a PICC port. So there's research basically from about 2019 up until now. Pinelli has probably done the research with the biggest cohort of patients, and that is in breast cancer patients. What is nice is that it increases patient satisfaction, quality of life for patients, reduces costs a lot, and it reduces complications. There's basically no major complications. Long-term complications might stay the same for a chest port as for arm port, but no big short-term complications. Just for those that doesn't know, here on the left side, I was inserting the first PICC-Port in October last year. And you can see it was a patient. You don't need a theater. It was done next to the bed, and there's 3 stitches and then some dermabond glue on, and the port could be used immediately. So basically on the right side, you'll see that's the normal PICC line that we insert. That's for patients that receive therapy for less than 3 months. If it's longer than 3 months, then you'll convert to a port, which is the second picture there. And that is just an extension of the PICC line. So the PICC line will then basically become a PICC port. It will be a new insertion, but if you know that the patient is going to be on therapy for longer than 3 months, you will obviously go for a PICC port from the beginning. What made this new, the brachial port didn't really work. What made this new was there was the SIP bundle that was released by the Gavisheld guidelines, and that Stefan is going to go through. But the main 3 points there is the insertion is in the proximal 1/3 of the arm in a bigger vessel, and we ensure that we don't deplete more than 1/3 of the vessel. And then we need to respect that protocol well. And then we don't have a lot of complications. In fact, in Pinelli's research, there was something like less than 1.1% complications. So what makes it super safe, obviously, is that there's no chance for pneumothorax, no chance for hemothorax, because you're working in mostly the brachial vein. I mostly use the basilic vein, then brachial vein, and in a very small percentage, the cephalic vein. There's no chance for hemothorax. The cost is much lower. You don't need a theater. You don't need anesthesia. You don't need a surgeon. And so you can basically do it in a separate procedure room. In Italy and in the National Health Service, it's done by vascular access nurses or vascular technicians, as they call them there. Obviously, you will see that aesthetically, it's much pleasing to the patient than having this old chest port on the patient or a PICC line like this. So at the end, I think the questions should change not from must the patient get a PICC port or a chest port, but must the patient get a PICC line or a PICC port? And so you need to make that decision, and that decision can be guided with the Gavisheld guidelines. In this is just an easy way of deciding which one you're going to use. Mostly, if treatment is going to be longer than 3 months, then we will insert a port. And in this case, if a patient's got a superior vena cava syndrome, we can also do something which is called a PICC port or a chest port or a chest to arm port conversion. But all of these things are possible now. So out of hospital use is probably a line that the patient will have in a PICC line and in hospital, a totally implanted vascular device. Factors that we look at is the coagulation profile, and most of them you just have to omit the last dose. There are tables that you can look at, which we can send you. Patient preference, and most patients, especially in the article from Pinelli, is that it's much better for the patient to have it on the arm and not have it on the chest. Funding, the cost of a PICC-Port is much less than a chest port. The PICC-Port probably about 20% of the cost in terms of the total cost. Then one must also look at the patient's environment. Will they be able to look after the PICC-Port? And obviously logistical considerations. Can the patient come into the hospital with a PICC-Port? You can immediately start giving the chemotherapy, so you don't have a waiting time. We implant it on top of the fascia with a little cut, 3 stitches, and just covering the wound. There's an article of the coagulation profile that you can go and have a look at. But if you look at it, most of them is just omission of the last dose of your anticoagulation, and then you can insert it. Most of them don't bleed. The tunnelers are blunt, so you really don't lose any blood. Most of the time, use 3 or 4 gauzes to insert it. This was a study that was done to evaluate the quality of life for women with chemotherapy between PICC lines and PICC-Ports. And at the end of the day, both of them had the good and the bad areas, but mostly it was in aesthetics. It was much better for women to have a line on the arm with a psychological issue around the breast cancer and so on. Interesting, in Italy, they insert it mostly for lung cancer patients, but the study was done for breast cancer patients. There's PICC-Port, some of them you can't even see it, so it's difficult to find them. That also can be a problem when giving the medication. So I think the first study started appearing in 2019, and then the PICC-Port is just inserted. It's the same methodology as a PICC line. So you will insert a PICC line, and Stefan will explain to you later, the PICC line will then just be converted to a port. And there will be certain protocols on the sub-protocol, which is the ECG, which we call the intraluminal ECG, and we can use the bubble test or the echo tip protocol. So we don't take any x-rays as well. We determine the exact place where to put the line. So it is much safer for the patient at the end of the day. There are some articles that you can go and have a look at, and most of them is about the longevity and the quality of life of these patients. The first ones had a little cohort of patients, and then the bigger articles came. This one had 4,480 patients, and they only had a device failure rate of 1.2%, which is exactly the same as a chest port. So you have got no of the initial problems of a chest port and the same problems later on. So there could be catheter-related thrombosis later, there could be infection later, but initially it is a very safe port to insert. Mostly research done up until now was in breast cancer, and especially because we want to avoid this area where they're going to get either surgery later. One of the issues could be surgery, where they remove nodes, and then we need to go to a PICC line, which we can insert into the femoral vein. So PICC-Port, equal incidence of late complications compared to chest ports. So everything is the same. There is no more problems with that. We look at quality of life, and they've studied that perfectly with the studies in Italy. Currently, they have done more than 6,000 PICC-Ports on patients with breast cancer. The late problems is exactly the same as the problems that comes with chest ports. So for PICC-Ports, same with chest ports. So you don't need all of these expensive things like fluoroscopy, a radiology room, operating room. You don't need anesthesia or anesthetists, just local anesthetic And Stefan will explain to you just now how easy it is to insert the PICC-Port. So there's no doubt that there's none of these problems, no pneumos, no hemos, no arrhythmias, no bleeding, lower average cost. And as I said, some patients even sit while you insert them because they don't want to lie down or they can't lie down. So I'm going to go as bold as saying there's no doubt that the PICC-Port should be the first option for patient, not chest port. So there are contraindications. The same applies to chest port, but in PICC-Ports, be sure for patients with renal failure that they cannot receive PICC-Ports. We need to look at the arms and keep it available for fistulas and so forth. And obviously patients with superior vena cava syndrome. And the rest are all false contraindications. They say in obese patients, sometimes it's easier to insert them in obese patients. You can do a port for a chest to arm conversion. So there's a few different conversions that you can do to get the port to the arm that you'll do with tunneling. This is just a picture of how they do it. They started at the chest on the left and then they converted to the arm at the end. So there's just little 3 holes made with the line have been converted to the arm. The PICC-Port goes into the femoral, and then we also tunnel it much closer to the knee. So it goes into the superficial femoral vein, goes closer to the knee, so there is no chance of infection. So it is also an option, especially for those patients that cannot receive a line in the upper part of the body. This is how the PICC-Port, the femorally inserted central port, is inserted, and then they can be used. So nobody will ever see there is a port as well. That port, we confirm that with transhepatic ultrasound and also the bubble test. Stefan will show you the bubble test. We do the same with the PICC line. Make sure it is in the correct position and basically the same procedure. So the take-home message is that the old strategy is that chest ports were always everywhere implanted. It was implanted by self-taught physicians. You had to have the operating room. You had to have fluoroscopy and post-procedural x-rays. None of that is necessary anymore. We use other ways of tip location, and you can do it in a procedure room or even bedside. This is a new strategy where there's optimal cosmetic result, low cost of the maneuver. In the whole of Italy, it's inserted by vascular nurses, no complication at insertion, very accurate tip location, and we don't have all the other problems that we have with funding at the end of the day. So remember, there are no significant differences between PICC-Ports and thoracic ports in terms of duration and late complication. Exactly the same. They can stay in the same time, duration, and they've got the same long-term complications, whilst PICC-Ports does not have the short-term complications. And also consider that there is other options like PICC-Ports where we can insert the port into the superficial femoral vein and tunnel it to a easy place. Stefan is going to show us a bit later exactly how this is inserted. Thank you for listening to me. If you need to contact me, there's details. Thank you, Luke.
Perfect. Thank you very much, Dr. Minna, for giving us the foundation of what we need to understand about PICC-Port, specifically in the international context. But now we're going to listen to Dr. Liana Rood explain to us how this fits into our context as South Africans. And her topic for this evening is the case for PICC-Ports in resource-constrained settings. A very interesting topic, very close to home. Over to you, Liana. Thank you.
Thank you so much to Andre and the Zebra Medical team for inviting me to be a panelist on this very important and very topical discussion. Today I am less here as a surgeon, but more as a health advocate, and specifically looking at the great potential that PICC-Ports have in resource-constrained settings as what we are experiencing in South Africa. Now, I would be frank, I have only recently undergone training for the PICC-Port insertion, found it hugely helpful, very, very interesting, and I can absolutely see how these ports can make a huge difference in the lives of our patients. So we are all very familiar with the vascular access dilemma, especially in low-income settings, of which South Africa, of course, forms part. It is, and what we're sitting with at the moment is a massive disparity to what is available to our patients in the public sector and what is available in the private sector. Mainly because of the traditional vascular access options that we had. So we had the traditional port that was inserted on the chest wall, which often became problematic in the public healthcare sector due to operating bottlenecks. And then our traditional PICC lines, not our PICC ports, which posed a very high maintenance burden. So neither of these options actually gives us the ideal solution in a resource-constrained setting. So the external lines, we know they are very cheap to insert at the bedside. We are talking simply now about our standard PICC lines, but they do require weekly clinic visits for flashing, for dressing. They do have a higher risk for infection and for thrombosis. And there is quite a few reports of patient quality of life reducing markedly. Our traditional chest ports, on the other hand, are quite low maintenance and they're quite invisible to the patients, although they can be uncomfortable. But they become prohibitively expensive, mainly due to the fact that they have to be inserted in the operating room. We have fluoroscopy that needs to be available, and we've got surgical costs. So in the public healthcare setting, this immediately excludes this as a viable option for many, many patients. In comes the PICC-Port, which really solves a fantastic problem for us. So the methodological synthesis is that we use, as with a PICC line, a brachial port, like we would with a PICC port, with a normal PICC line, but that the port is actually hidden in the patient's arm. So it combines the low-cost bedside insertion of a normal PICC line with the invisible, low-maintenance safety of a fully implanted port. It sounds almost too good to be true. So if we just quickly compare these various vascular access modalities, we look at the standard PICC port, the traditional brachial port, the chest port, and now the PICC port, we can see that there are clear benefits to seriously considering this as a wonderful solution, especially in our low resource settings. We can do the PICC port with ultrasound guidance in a procedure room or at the bedside. The maintenance frequency is as low as the chest port with monthly flashing. Our immediate complication risk is almost zero or negligible, and the cost to the system is by far the lowest of all the modalities available. So there's quite a few studies, and I have included some references that you can go and look at, but that clearly show massive savings with a single procedure. And that is just when we're looking at the insertion cost, not even speaking about the maintenance cost. When we look at the regularity and the intensity of maintenance between a PICC port and a PICC line, you can hardly compare the two. The PICC port is far easier to maintain and has a far lesser impact on patients' quality of life. We also have the benefit of the eliminating immediate complications, especially if we do it in the right way. If we do it with pre-procedural ultrasound, we do an ultrasound-guided venous puncture. We include an intracavitary ECG tip location to make sure that the port is placed correctly. And we can actually use glue, and we don't even need to use sutures, to enclose this very small device in the patient's arm. There is a significant number of studies that is convincingly now coming out showing that we can reduce infection and thrombosis risk with the insertion of PICC ports. They are fully implanted, they are fully sealed, and if the right catheter is in the right vein, we immediately lower our risk for thrombosis. Down the line, this obviously also leads to cost savings and is very important when we look at this in a resource constrained setting. very important from a patient advocacy point of view, is that this helps us to preserve patient dignity and quality of life. Patient satisfaction score with these PICC-Ports in studies comes back incredibly high. And when we look at what our public healthcare patients are currently dealing with, which is often no port at all and no vascular access at all, and what that does in terms of how they experience their chemotherapy and their quality of life, this really seems like a miraculous alternative. So, in my opinion, this device really does offer the opportunity for us to try and solve structural healthcare barriers, especially in the South African setting. So if we look at it in the whole, we have three forces working together here. We can task shift because insertions can be safely performed in a procedure room. It can even be inserted by specially trained nurses or other healthcare professionals. It does not have to be necessarily a surgeon. You have definite relief on your supply chain with a lot less consumables that are required, and we have much higher geographic access of these devices. So if you do the simple value equation, you've got zero fluoroscopy, you've got zero surgical theatre time here, you have task shifting with your insertion, more professionals that's being able to do it, vascular access team, you've got low complication risk, superior safety, and very important, you've got patient dignity, which really gives us, when you look at it from a health economics and a health systems and advocacy point of view, provides maximum systemic value, which is why I feel very comfortable actually and very excited to support the rollout of these PICC-Ports and hopefully also beyond the private sector into our public sector. So how do you get started? Three very simple steps. Acquire the basic technology that should be available in your hospital. Establish a vascular access team that get trained. A lot of hospitals will already have healthcare professionals that is proficient in this. And then adopt the PICC-Port protocol. So actually do the standardized training, do it with ultrasound guidance, have all your safety measures in place, and you have a high success rate and a very low complication rate with the insertion of these ports. I think these ports are probably set to become the definitive standard of care, especially in resource-constrained settings. We cannot afford the high complication rates of standard PICCs, and we cannot actually afford the surgical bottlenecks and the lack of implementation of traditional chest ports. So this offers us a systemic, efficient, multiplier solution to a problem that we have with patients requiring chemotherapy. And here is all my references for further reading should you be interested.
Thank you very much, Dr. Loort. I think that really gave us some good insight into at least one use case that can be scaled across our needs in South Africa, especially in terms of patients in resource-constrained settings, but also how this can even impact the private sector from a cost-saving and value-based care perspective. So really interesting topic, and thank you very much for that. So we've now gone from international perspective, local perspective. Let's look at the practicalities of this. And for this, we'll have Dr. Stefan Besson speaking on the topic of PICC-Port insertion and care, something that is often forgotten, the care part of things, and looking at the Gavasalt PICC-Port bundle, which both of our previous speakers have spoken to. Stefan, over to you.
Thank you, Luke. I'm going to take you through a presentation about PICC-Port insertion and care, and this is based on the Gavasalt PICC-Port bundle. PICC-Port stands for the safe insertion of PICC-Ports bundle. So, of course, with a PICC-Port compared to a traditional chest port, we are prioritizing quality of life in cancer care. And if we look at a traditional port or traditional external lines, these lines are obviously visible to people outside and draws attention to the chest wall and the arm, whereas a PICC-Port provides some freedom. It's virtually invisible in the upper arm. It can be concealed underneath a piece of clothing, and ladies can even wear bathing suits or swimwear without fear of other people seeing the port. So when we look at the support bundle specifically, this is an 8-step blueprint that has been proven to be very safe and effective in guiding PICC-Port placement. If you follow this protocol, it has been shown to have almost a 0% chance of dislodgement and almost no complications. So this is broken down into 3 phases. The first phase is the assessment phase. So you will use ultrasound to map out the veins in the arm, in the upper arm, and also looking at the subclavian and internal jugular veins on the side that you want to insert your PICC-Port. The second step is antisepsis. So we use an aseptic technique when inserting these lines. We sterilize the skin and maintain strict hand hygiene. And then also the third step refers to strategic vein selection. So remember that you need to measure the vein that you're targeting, whether it be vascular or brachial, even axillary. And this vein needs to be an appropriate size for the size catheter that you want to insert. We don't want the catheter to take up more than 1/3 of the size of the vein. The second phase refers to insertion and navigation. So the fourth step is your micropuncture to gain access to the vein. We use ultrasound-based navigation to track our introducer and to track our guide wire and to make sure that it's going into the right direction. When we've inserted our line and we do not need to use X-rays to locate the tip, we can use ECG and we can use intra-procedural assessment like echocardiography to check that our tip is in the right position, which we'll demonstrate a little bit later. And then the third and final phase is the pocket creation, where the port will be placed and then closing the skin with subcut sutures and dermabond or histochrolic acid with no need to remove sutures afterwards. So step 1 to 3 is the assessment and zonal placement phase. So here we divide the arm into 3 zones. So the yellow zone and the green zone is where you want to be. The red zone is where you want to stay clear of. This is more distal and closer to the flexure of the arm. Ideally, you want to enter the vein and cannulate and create your pocket in the green zone. If you need to go into the yellow zone for access, that is also fine, but you still want to cannulate and put your PICC reservoir on the green zone, so anterior to the bicep muscle. So the first step is your systematic ultrasound assessment. We use the RAPIVA protocol. RAPIVA stands for Rapid Peripheral Venous Assessment. And we want to see that all the veins in the arm are patent, that there's no thrombus, and that you can follow those veins proximally and see that they are clear. The second step, again, refers to antisepsis and barrier protection. We wash our hands with chlorhexidine and isopropyl alcohol and then prepare the skin with that as well. And we maintain an aseptic technique throughout. And then this third step refers to zonal placement and vein choice. We want to target the middle third of the arm, and we want to maintain a strict 1-to-3 catheter to vein ratio to prevent thrombosis. And as I've said, if you enter the vein in the yellow zone, you still want to tunnel and make sure that your reservoir is planted in the green zone. So if we look at the bottom there, you will notice that the size of the catheter will correlate to approximately to the size of the vein. So 3 French catheter can go into a 3 millimeter vein, 4 French into 4 millimeters, and so forth. We typically use a 5 or a 6 French catheter for our PICC-Port insertions. Steps 4 to 5 refers to our minimally invasive venipuncture. So when you've done your ultrasound of the arm, you need to identify the brachial artery and the brachial vein, the basilic vein, and also the median nerve. You look for the Mickey Mouse sign where the brachial artery will sit in between the brachial vein and the basilic vein. And ideally, you want to use the basilic vein as it's a little bit further removed from the median nerve. Our 6th step is our ultrasound-based tip navigation. So the first step is we can see in real time where our guide wire is heading. So if we do basilic vein access, for instance, you can see that your guide wire is in the vein. You can follow that up into the axillary vein, into the subclavian. And if you do a supraclavicular view of your subclavian vein, you will see the guide wire going down into the brachiocephalic vein. If you're not sure that it's going down, you can scan up into the internal jugular and make sure that you don't see the wire going up into the IJ, either on the right or the left. This is, of course, a fast and quick thing to do. It's significantly cheaper and safer than relying on traditional surgical fluoroscopy. And if you see that you've misplaced your guide wire, you can remove it and do some maneuvers like manipulating the patient's head to the left or the right, or manipulating the arm to ensure that your guide wire goes into the right direction. Step 7 refers to confirming placement of the catheter tip. So the gold standard is ECG-based tip navigation, where you will connect the line to the red port on the ECG monitor and look at P-wave changes. We will demonstrate that in a video a little bit later. And the second step that we also use to confirm is called a bubble test or a saline swirl test, where you can do transthoracic echo, either in a parasternal long axis or a subxiphoid view, and look at the right atrium and see the bubble swirl in the right atrium when you inject the saline. We will demonstrate that with a video as well. The final step is pocket creation and port placement. So once you've identified the site for your ports, you're going to tunnel from your insertion site to the port site. You're going to make a small incision of about 2 to 3 centimeters and blunt dissect with the tip of your pinky and make a small pocket for the insertion of the port. So here you'll see first hydrodissection, and that we use just lignocaine or any other local anesthetic of your choice for. And that creates a pocket just below the skin overlying the biceps muscle. The second step would then be implanting the device in the subcutaneous tissue and just confirming that it's working. And the final step will be closing your wound with some subcut sutures, which are absorbable, and then sealing the wound with skin glue, either histocrylic acid or thiacrylate glue, whatever is available to you. And this wound is then covered with a tegaderm. So the first video we're going to show you is just how to perform a bubble test or a saline swirl test.
So this is how we activate the saline. We've got a sort of apical 4-chamber view there, with the left ventricle to the top there, and we're going to see if we see a cloud in it within 0.5 seconds. So I'm going to turn this. Everybody have a look at the screen, inject it. There we can see the cloud inside, and the cloud's gonna disappear, so it's in the right position. Okay. Yes. Okay. So it was
Yeah.
So
it was in the right place.
yes, so,
Amazing.
so the other option is to do it with
X-ray.
or intraluminal ECG. So
Wow.
so that's the best way of doing it.
How do you even do it? Oh, yeah.
I've got a connection.
You said,
Yes.
yeah.
Dis 'n heeltemal 'n nuwe studieveld, ja. Mevrou is een van die min eerste mense wat ons dit so doen.
You're lucky, hey?
Nou hoef ons nie gat in jou nek te steek. Hoef jy nie heeltyd te puncture nie.
Do you want this?
Yes, yeah. So we'll always put it like that. It was slightly too slow for me. So we might be a bit too shallow, but that's not a problem.
In the next video, we're going to demonstrate the ECG tip navigation, just to show you the change in P waves and what you need to look for to ensure that the tip is sitting in the distal superior vena cava and not inside the right atrium.
If you look at the ECG monitor there, that's a defibrillator. And now that is connected to lead number 2, or the red lead patient's arm. And as they advance the catheter tip, I want you to watch the P waves on the monitor. And as the tip comes closer to the distal superior vena cava, closer to the right atrium, those P waves are going to start peaking. And when they're at their peak and sort of at the same height as the QRS complex and the R wave, that is where you want your tip to be placed. If you go past and into the right atrium, the P wave is going to go into a negative deflection, and then you know that you're too deep.
And then the final video that you're going to see is just a demonstration of the whole process of insertion from start to finish.
So first here, he is finding his basilic vein, and then is measuring the size, making sure that it is big enough for the size port that he wants to put in. He's injected some local anesthetic there, and now he's entered with his microneedle, inserting the guide wire. Needle comes out, and now he's just going to check his guide wire position, that is in the supraclavicular view of the subclavian vein. We're seeing that it's going down. He's putting in his dilator. He's attaching the red lead. He's going to do his ECG tip navigation now with the intraluminal ECG. So they will show us, there's catheters going in. If you look at the bottom lead there, you will just watch the P waves and you'll start seeing them peaking. Now it's just going to check that his catheter is in the lumen. There you can see the catheter in the lumen. And he's happy that his catheter is well placed, going in the right direction. And there, just watch the P waves as they start peaking. And there you can see on the bottom screen that it's almost at the same height as the R wave. It means the tip is in the distal superior vena cava. That's where we want it to be. It's measuring it on the skin. And now he's going to just map out where he wants to do his tunneling. And he's creating the pockets. See access quite high into the axilla. He's injecting lignocaine or local anesthetic, making a hydro pocket. And some local anesthetic for where he's going to tunnel. Making a 2 to 3 centimeter incision. And then he'll blunt dissect with the tip of his pinky, just to create the pocket for the port. And he's going to fit the port in there to see that it fits nice and snugly. So port is fitting well. He's going to take it out now again. And then he will tunnel the catheter through. So as you can see, there's a little bit of blood, but it's really not a lot. Okay, so tunneler is connected and he's pulling his catheter through nicely. Just making sure that it doesn't kink and that it doesn't pull it out of position. It's going to now cut off the tip and then connect the catheter to the actual ports. And then bury that in the pocket that is created. He's connecting it to the ports. It's going to insert it into the pocket now. Needs to sit nice and snugly so that it doesn't twirl around. Make sure that the catheter is not kinked. Now they're going to close that with 1 or 2 subcut absorbable sutures. There's just checking the port that it's aspirating and flushing well. And it's leaving some positive pressure in there. Just connecting a port needle. Will stay in there. They don't want to do a bubble test now just to confirm that it is sitting in the distal SVC, and there you can see the swill in the right atrium. So some subcut sutures, and then just closing that incision site with skin glue, and also where he did his tunneling.
Coming to the end of the presentation, just a word on port care and maintenance. So we want you to access the port with a non-coring needle. So this type of needle is called a Huber needle. We flush the port with normal saline, and we use a pulsatile lock mechanism. Of course, our oncology nurses should all be well versed in this, as it is the same process as they would use for traditional chest ports. That brings me to the end of my presentation, and I'm going to hand back to Luke now, who will take us through a question and answer session. Thank you.
Thank you very much, Stefan. So before we get our question and answer session, I think we can do a quick poll for our participants, which will be 2 questions. And then after that, we'll get into our Q&A section. Just a reminder that we don't yet have any questions in the Q&A section. A reminder how to navigate to that. If you look at the bottom of your screen where it says things like participants, chat, react, etc., you'll notice a little bubble that says Q&A. If you have any questions for our panelists, please share them here, and you can even direct them to specific panelists, and I'll be happy to share that when we get to that point. But for now, we've got 2 polls. The first question in the poll is, now that we have all listened to our esteemed panelists, let's do a dipstick. Who thinks that they or their institution needs PICC-Ports? So who feels that it would be a good idea to implement PICC-Ports in the institution? Our second question is then, if we said that Dr. Minal and his team could come to your institution and do some practical training, would you commit to trying PICC-Ports or promoting PICC-Ports in your institution if hands-on training is provided? So please have a look at these 2 poll questions. It will give us a lot of insight on how we can assist you with what you need in your institution, but most importantly, what your patients need. But let's move on to our Q&A session while you guys vote on the poll. So we've got 2 questions over here. From the esteemed Maxime, do you think it would be useful to suture the port inside the pocket to avoid flipping? I think I'm going to leave this one open to the whole panel. Anyone who's happy to answer, please jump in.
I think Pinelli, and I think if he inserted the most of the ports, and if you make a nice snuggly port pocket, it's not necessary to do that. In fact, he actually says that we shouldn't do that. We shouldn't suture the port inside the pocket. Obviously, you are concerned that the patient might start to play with the port or start turning the port around when it's inserted, but that doesn't happen so often. And if you make a nice port, it won't happen. So according to I think the mentors and the guys, they don't like to do put sutures inside. The only thing that we will do is just do maybe 2 or 3 buried stitches to bury the port. One, maybe last thing about sutures is that some don't even suture at all. They only use the glue. So if you have a cyanoacrylate glue available, you can just put the glue on and don't suture it at all. And if in the beginning, what happened with me is you accidentally make the pocket too big, what I did then was I took just some absorbable sutures just to make the pocket a bit smaller. So because in the beginning, you're not 100% sure how big your should be, and you should if you need to suture the pocket, the port inside the pocket. I don't know if any of the other panelists have got another idea.
Perfect. Thanks, Hugo. Liana, Stefan, anything from you guys? What I can say is sorry, Stefan, I just want to give some feedback from Maxime so far. He feels that good answer, great, thanks. Let's hear what you have to add there, Stefan.
So I haven't sutured any of the ports that I've inserted, and we haven't had any issues with this nursing staff not being able to access the ports as yet. I think the team from Zebra, the reps have done really well in providing support to the oncologists that refer patients and to the nursing staff in the wards and at their rooms with training. And that also helps just with accessing the ports and the aftercare as well.
Perfect. Thanks, Stefan. I think really important point that you're touching on, well, 2 points. Number one, training on aftercare of patients. Because one thing we don't want to end up with is a sort of fire and forget philosophy. We also can't leave team members behind in terms of skill. If we are going to be transferring skills to them, we need to transfer the full set of skills. So I think that's a very important point. Just to get into some more questions, they're starting to come in more rapidly now. I'll tackle this one from Shepard Mafolo. The question is, where can I get practical experience? Shepard, we will address that, and I think at the end of the presentation there are opportunities to get some practical experience, all of which are through Hugo Menard, but we've got some strategies to show you guys. Nico Lowe asks, do you find using in-plane or out-of-plane needle insertion easier? I'll also leave this one open to the panelists.
Definitely out of plane. So I only do out of plane and then just in plane to confirm my wire position. I think that is how all of us do it. I'm not Stefan, you can also add, but that's how I do it.
So if we access the veins in the arm, out of plane or in plane rather is okay if you are looking at a singular blood vessel. But where we're accessing in the arm, there's quite a number of structures very close together, including the median nerve, which you definitely don't want to hit, and the brachial artery. So there you need to use an out-of-plane approach to keep all of those structures in view while you're approaching the blood vessel or your target.
I think this is also very interesting or very important rather, because it shows the marriage between point of care ultrasound and also vascular access, and sort of the older culture within medicine. I mean, I think we can call it all older now, is sort of landmark-based access, but the trend is definitely much more to point of care ultrasound and now also newer techniques in achieving vascular access. So just back to the questions, I'm going to jump around a bit. We've got a question here from Dr. Nelson Alves, a very interesting question, I think, in the context of the wave we are seeing with the likes of GLP-1s, such as Wegovy, Ozempic, liraglutide, etc. His question is, with large patients who have lost a lot of weight, they have a lot of loose skin, and port flipping is a real issue in my experience. This is irrespective of how small the pocket is made. what recommendation would you have to approach these patients? Over to the panel.
Just want to ask, obviously he's obviously referring to his to chest ports, but it will come in the arm ports as well. You'll see that a lot, and that is where tunneling becomes important. So you're gonna have to find a place where there's not a lot of loose skin, and you're gonna have to tunnel the line to that position, and sometimes that position could be an awkward position. I've spoken to some of the specialists, the vascular access specialists in the rest of the world, and some of them might even tunnel the port to the patient's back area. Yet, so it's not necessary that the port have to be tunneled to the arm. You can tunnel the port, you can insert the port at any other place where you can tunnel it to. So I think it's important to, and we definitely have to up our tunneling skills to be able to tunnel a port to a better place. And I will then just tunnel it to a place with less movable skin at that stage. That was, I would think, of the fly.
Okay, thanks, Hugo. Just in light of time, we've gone a little bit over schedule, and obviously we understand if there are some hard stops for those in attendance and also those on our panel. So I'm just going to marry two questions and also just close the loop on Dr. Alves' question, which is he was referring to PICC-Port specifically. So Hugo, do you just want to add a layer of context there, or are you happy for me to move on to the next two questions?
I think you can move on. You need to find a place where the skin is stable, and then you need to tunnel it to that position.
Perfect. Thanks, Hugo. So I'm going to marry these two questions together because they both speak to patients' experience in this. So, and perhaps also to some degree provider experience. So is removal of the PICC-Port complicated? And then in terms of post-procedure pain management, is it a significant issue or is pain mostly tolerable?
We can do, all of us can answer this. They don't use lignocaine at all for this procedure in Italy. The ideal local anesthetic would be ropivacaine. The reason for that is that it works faster and it works for longer as well. So your narrow pin would actually be a better local anesthetic for these patients. And then you could give some pre-procedural pain medication, but if you do good local anesthetic with narrow pin or your lignocaine, and your lignocaine will typically be your 4 milligrams per kilogram with a non-adrenaline, and then the 7 milligrams per kilogram if you have got those with adrenaline. I just think that I did use narrow pin, and I use narrow pin when I do lines for children as well, especially for those that can't afford anesthesia. And it doesn't burn if you inject it, and it lasts longer. So I think narrow pin, if you have got that available and funding available to do that. Otherwise, like normal lignocaine and then just a proper pain medication, not just a Panado afterwards, because it is a painful procedure. You are making a little cut into the skin.
Okay. And then in terms of removal, where are the biggest concerns there?
So when you remove, everything's going to be the same. I would just suggest that one be prepared for bleeding. So have a little cautery device available so that you can cauter anything that bleeds. And this is actually a very important question. There could be fibroblastic sheath that is formed. And it actually forms with all the lines. You get a fibroblastic sheath, and even more so in patients with autoimmune disease. But that sheath, it's important not to try and remove the sheath. The fibroblastic sheath is almost yellow in color in most patients, and it looks like you have to also remove the fibroblastic sheath. Do not do that. If you pull on that, you're going to pull out the whole vessel, and the patient is going to bleed to death. So removing it is quite easy. It does bleed a little bit more. So I think your lignocaine with adrenaline should be used there. Have a little cautery device available, and you can remove it like that. I had to remove a doctor's wanted to remove his port, and he said I must do it in his rooms. He doesn't want to go to someone else. So then we just had it, and the removal was quite easy.
Okay, thanks, Hugo. We've got one more question then left in the Q&A box, which I'll then take as the last question. And that's from Andre Barbosa. What do you connect the lead ECG lead to exactly when doing the intraluminal ECG technique? Do you need specific equipment? I think that's a really important question because, I mean, if you're thinking about costs in specific centers, it might mean the addition and purchase of additional equipment just to be able to do this single function. How does that look in reality?
Luke, so there's two options. Where we've done the procedure in a procedure room with an anesthetic machine, we've used the monitor, just a normal ECG monitor that you would connect your 3-lead ECG to. So that has 3 leads, green, yellow, and red. So you would take off the red lead, and there's a little red a lead that comes with the port package. That lead is connected to the tip of your catheter that you've inserted, and then it extends, and instead of the ECG lead connecting to the patient's chest, you connect it to that red tip that's connected to your catheter. And you can then see that strip on lead number 2 then reflects your intraluminal ECG. If you don't have a monitor, which you probably should have, you can also use the defibrillator and just put it on its monitor setting. And both of that will work equally well.
Okay, so it's effectively device agnostic is what you're saying, that you can use what you have available. This would be in the kit that you then just need to purchase your intraluminal ECG device, and it's as simple as that.
Yeah.
Okay, perfect. I see that we've got 2 questions that have snuck into the chat. Sorry, Hugo, did I cut you off there?
Yeah, it's just important. The wire does not come with the kit. It's a separate wire that you have to buy. So the wire for the intraluminal ECG does not come with the PICC-Port kit. It's a separate wire. That's why some doctors have developed their own things to connect to the right arm lead. So you can, and I wish I quickly tried to get on my phone the video of that I found that someone in India made. They had a few clamps and things, and they made their own sort of device to connect the lumen to the ECG. So it's the saline that's inside the lumen that acts as the conductor. So you just need anything to connect to that saline and insert something to it. And so they had some clamps and things which they've used to actually make their own. And then there's obviously devices that you can buy, very expensive devices to buy that you can put on the screen and so forth. I don't think that's necessary. I think the normal ECG connector is fine, but it comes separately. It unfortunately not come with the kit.
Yeah, I think please correct me if I'm wrong here, but I think the one that is accessible is the Vegon iCard. I think that's one that can be used.
Yes.
Perfect. So like I mentioned, thank you, Hugo, thank you, Stefan. I've got two more questions that were in the chat and not in Q&A, but we're gonna ensure that we are bringing value for our attendees. First question, we've got two versions of it. I'll go with the first version in the chat, and this is from Mohammed Rafi Ghafour. And the question is, how accessible are these ports in the arm for the needle? Are there any oncology nurses in the audience that can answer this? Okay, perhaps not the audience, but essentially the question is, how accessible are these ports for oncology nurses?
I think oncology nurse should actually answer that, but my feedback from the oncology nurses is that it's easy for them. They are used to the chest ports. The only challenge is those bigger patients, and if the port starts to move, it is difficult for them to find. So yes. It is a better question for a oncology nurse to answer, but the feedback that I get from them is that it's not a problem, especially with the type of needles that's being supplied by Vigon. It's not that difficult.
Thanks, Hugo. And then last question for Hugo, Liana, or Stefan will be from Andre Stradom. In your practice, have you been called to remove your port because of a bacteremia or similar, notwithstanding your aseptic technique? Thank you for the value talk, Andre Stradom.
Luke, I haven't
Yes,
had
Stefan.
to remove any ports yet. I haven't been inserting it for that long, but as yet, no complications that required removal of the ports. No.
Okay. Thanks, Stefan. And Hugo, Liana, you guys?
Same. We haven't had to remove.
Hi, Luke.
Okay.
Hi, Luke. Sorry. No,
Hi.
I mean, also, I can't say that I've got extensive experience, but so far, nothing for sepsis. And the one thing, and I know it was discussed previously, was the flipping of the port. So we've had one patient, and I know it was just the pocket size, and the patient was quite fiddly. So we actually had one port that flipped, but it was quite easy to correct that. But for sepsis, no, so far, nothing.
Okay. I think that's really interesting. I mean, especially in the context of the type of patients that you also see, Liana, who are immunocompromised to some degree. I think that's a very interesting point that you're raising. Granted, you did disclose that this hasn't been an extensive part of your practice, but has been a recent and valuable part of your practice. But I think we can close our Q&A session over there. Thank you very much, everyone. Thank you very much to our esteemed talkers. Sorry, guys. It's a late night. I think we're all there right now. But our esteemed panelists, to answer the question that was asked by Shepard, yes, there will be some training available. I don't know if we have a flyer available to the team in the background, but there is a course that will be happening in the Free State in this month, the 27th of this month, regarding midlines and PICC line placement. So that's a start in terms of alternative forms of vascular access or more advanced forms of vascular access, with PICC-Port insertion training also coming very soon. So please have a look out for ClinIQ Medical's LinkedIn page. There should be some information over there, or reach out to Zebra Medical. They'll surely share information about how you could get access to this course and courses like it, not just through the one provider, but through any provider that's available in South Africa. But yeah, thank you very much to everyone. Wish you a good night, and over to you, Andre.
Yeah, thank you, Luke. I think you've summed it up really well. Really appreciate all the attendees. It was a fantastic turnout. And in terms of our poll, it looks like the PICC-Port is incoming to a lot of your institutions, and we will make sure that the requisite training, which is key to success, is going to be provided. Thank you, everyone, for your time and for joining us this evening. Thanks.